Heroes in Prevention is an organization-wide effort to break the chains of infection, to go beyond hand-washing programs and flu shots, to create a whole new approach to minimizing infections.
Well, welcome. This afternoon we're going to be talking about ways that we can, this is not a class on community immunity, is not a complex isolation procedure or the pharmacokinetics of all the antibiotics. It's really doable, practical steps that we can add to the programs, processes, and policies that we already have that can markedly, and we have some evidence, reduce the rates of infection in our communities. I'd like to start, however, with, first time, with telling you a story about when I was in my early 40s, a long time ago now. I went to visit my parents, and they lived in a kind of semi-retirement community. And it was a really bright, sunny morning on the Olympic Peninsula in Washington, and I got up and decided I'd go for a run. And I was out running in the countryside, and two women were coming towards me. They were walking, and the closer I got, they were looking at me, and I got close enough I could in voice distance, and one of them said, "I just love it when you kids are out of school." She was pointing at me in my 40s. I'm not that tall, and I had shorts on, and her sight was probably not that great. So then I was quite thrilled about that. But a few weeks later, I took my children to swimming at the YMCA. We were swimming, and my daughter and her friends and I decided to sit on the side of the pool for a little while. And there was a group of 13-year-old boys in the middle of the pool, which is Kelsey's age. And I hear one of them saying, "Hey, check out those girls." And another one says, "Where?" And he points to where we are, and he says, "Which one?" He says, "That one sitting up there next to the old lady." He was pointing at me. So in that case, I think it depends on your perspective. In that case, I was quite affronted. But here we are. There are some unavoidable age-related changes that happen to us, right? And our vulnerability to catching infection, and of course being exposed when we're living in congregate settings like our residents are, puts us at higher risk. So we're going to talk about some ways that we can try to address that. Our goals for today are to understand a new concept, which is a web of infection as opposed to a chain of infection, and how can we make some steps to shred that web. The second goal is we want to learn how we can add and tweak to our daily practices that we are already doing. If you're in nursing home, you're already obligated to be tracking and doing some quality improvement projects, and we're going to talk about that. And finally, we're going to develop an action plan for developing community immunity or improving community immunity in your settings. So I want to really have you walk out of here today infected with community immunity. We all know, I really am sorry about this. We all know that germs are travelers. They don't even have to pack. They got everything they need, and they can get all over the place really easily. By the way, in the center table here, there are some gifts for you, some wipes if you'd like to have them, and then we're going to be talking about a case study, and there's a write-up on it there too that you can pick up. A quick snapshot of a history. It has not been all that long that the germ theory was discovered or came about. This guy was a Dr. Semmelweis, born in Hungary, lived in Austria, and he was teaching medical students. He got to the point where he was observing, and he was seeing how many women after childbirth were dying. You may have heard his story. So he starts looking, why is this happening? He notices that there are midwives delivering babies, and the women were dying 5 times less by the midwives. They were delivering babies, having the women lay on their sides. The doctors were having them lay on their backs. So he thinks he has it. He's starting a root cause analysis here. And so he has the doctors flip the women on the sides. It didn't make any difference. Then he notices that the priest would go up and down the hall when a woman would die, ringing a bell. So he thinks that they're getting frightened because they hear the bell and then they die. They get infected and then they die. So he tells the priest to lose the bell and to take a different route. That doesn't work. So it occurs to him, the doctors, but not the midwives, are doing autopsies on these dead women. And then they're going over and delivering a new one, and they got little cadaver particles on their hands. And he gets the notion that perhaps there may be something going on here. So he gets the idea, and he starts really proselytizing almost on washing hands. The doctors were affronted all over the place. He got very, very intense in telling them they needed to wash their hands. So badly, he says, I don't have any science behind it, but he just believed it. He got so wrought up about it, he finally, his behavior became bizarre, and he was just so stuck on it, he was admitted to an insane asylum. 2 weeks after his admission, he died from sepsis. At the same time, he's working here in Austria. Oliver Wendell Holmes in the United States is having his medical students wash with chlorinated lime. They didn't really have any idea about the chlorine, which we know is the best killer at the time. They just knew it took away the smell of their autopsies. And of course, Florence Nightingale, this is in the middle of the 1800s. So Florence is reading about the Crimean War and people dying, and she comes up with standards, and she has, she's very strong on policies and hand washing and containment of, particularly of fluids, lung, like what I'm spewing. Although you won't get sick, it's not contagious. And then we've got Alexander Fleming, so these guys are all, the other 3 are working on prevention. Alexander Fleming, by accident, discovers, as you know, penicillin. He kind of dropped it because it happened by accident in the first place, and he was busy doing other stuff. But so 10 years later or so, this was 1928, 10 years later, so it gets picked up, penicillin is discovered, and we use it in World War II. It's really our first big experience. So we have now a way to actually react to and try to manage it. What we're saying today is it's time for another disruption. And we have the opportunity to polish what we've been doing in a way that can make dramatic, as I'll show you, dramatic improvements in our rate of infection, our rate of hospitalization, and our rate of rehospitalization. Infections do occur and do create panic. Right now, we're all worried about what? Zika. Mm-hmm. And what have been some other things that you've heard that people have gotten frightened about? AIDS. Remember the first AIDS patients who came to live in long-term care settings?
The flu virus that wasn't correct. The one when they, and they were worried about the other strain of
the
flu.
flus. Yeah. What about Ebola? Mm-hmm. I mean, it's not like they're not legitimate concerns, but we just have to center ourselves and try to think, what is reasonable, what do we need to do to be prepared, both prevention-wise, and if we end up caring for and supporting someone, then what do we need to do in those cases? This is not the usual at home, and nor does it need to be in our centers. What we're talking about really is cleaning and disinfecting. So we want to think about when we clean, what we clean, how we clean, and how often we clean. how big is the problem in long-term care settings? This recording's not going to come out that great. In long-term care settings, think about any congregate setting. Think about right now. You know, we're in a setting where we are at higher risk for contamination. I'll stand back. And in schools, in daycare centers, in hospitals, in convention centers, and in long-term care settings, right? So infections are the leading cause of acute illness in long-term care. That's probably not a surprise because most of you are there. Sometimes we think about fractures or we think about a heart attack or stroke. Infections are our primary problem. This was done with a study with individuals who are incontinent, so their risk is higher already, 161. So what we find is that 4 in 10 over a 6-month period will develop respiratory infections. And within a month, the mortality rate is 10 to 30% for those people who are experiencing this respiratory. Gastrointestinal infections, 36% in a 6-month period, and urinary tract infections, 1 in 5 developed, and so that was a 23%. Pneumonia and urinary tract, that you can see on the left there, the three of the several leading causes of hospitalization are UTIs, pneumonia, and upper respiratory infections. The other medical situations would be dehydration and what? CHF, congestive heart failure. So how expensive are infections? A lot of times we don't think about what is the financial cost and impact for unreimbursed output of money. The annual cost for a nursing home bed of 100 beds, nursing home with 100 beds, would be around $50,000 a year. A quarter of the infections lead to hospitalization. I don't know how many of you are working on infections as one of your goals? Anybody? A few people. Okay. And have you found that you're at a quarter of people going to hospital? Or have you tracked that? Are you tracking that? Yeah. It hasn't been that high for you? Okay. 10% of these people get rehospitalized, and these hospitalizations make up 70% of the cost. 4 infections make up 30% of the primary diagnosis groups: septicemia, pneumonia, urinary tract infection, and aspiration pneumonia. Now, this first statement is from a Japanese study that we'll return to in a little bit. It found that death from pneumonia decreased substantially with oral care. That's the take-home message. If that isn't an imperative, a call to action for us, I don't know what is. The second one is equally outstanding. E. coli from the resident themselves was found to cause nearly 80% of urinary tract infections. So what does that say to you? We'd have bad care practices. Either the resident can't clean themselves good enough, and we are not coming back around to support them and get them cleaned good enough. That's terrible. And the fourth one, poor hand hygiene is the biggest risk factor for more than 80% of norovirus. So what's that say to us? We're kind of crappy at hand washing. You know, we teach it and we know that's a basic tenet of our prevention, but we're not doing a very good job. Now, you can know pieces of information. You can know a piece of information like that blueberry bushes, two different varieties of blueberry bushes planted close to one another will get cross-pollinated by bees, and they'll yield more berries off of both bushes. And that's a nice piece of information, but it certainly isn't a call to action. You can do something with it or not. When you see this kind of information, you cannot not do something about it, right? Say yes. So 68% of all Medicare recipients who got into sepsis, those cases stemmed from, they got septic from a urinary tract infection or a pneumonia. Everybody is obligated in nursing home to have an infection preventionist position. We used to call it the infection control nurse. The terminology today is infection preventionist. We all have to have a plan. The ones, I'm just going to pick out a couple pieces of it today that are relevant to the pieces that we're talking about today. And the first is this, oh yeah, that is it, is establishing policies and procedures. And we're only going to talk about the first three. Hand hygiene, I just got done saying, and I don't know how many of you episodically monitor hand washing and see how compliant we are and how good we are at it. You know, so washing is one piece, and then how the efficacy of it is the second piece. And whether we use soap and water or hand sanitizers, part of the plan has to be that they need to be accessible to people and in places where they'll be used well. And it doesn't matter whether it's a gel or a spray or a foam or whatever form. Standard precautions is the exact same. We don't have to be telling families, and we don't have to be using gloves and masks and gowns for every single piece of care. We have to have a procedure for when those things are to be called out. And finally, education for employees. I just, by a show of hands, how many of you do more than more prevention of infection education beyond orientation? Are you obligated annually to do something? Yeah. Okay, how about beyond the annual obligation? A couple. Okay. At the beginning, we talked about Alexander Fleming coming up with penicillin. It has now been just 75 years since that came out. We already have developed a lot of resistant bacteria, and there are a lot of antibiotics in the pipeline being worked on right now. So we have an obligation, all of us, whatever our position, doesn't have to be just the nurse, to be thinking about what we call antibiotic stewardship, which is what? Yeah, being
carrying out the care practices that would prevent infection or stop that. I know you said not change it, stop prevention, so that we don't overprescribe antibiotics.
mm-hmm.
There's an E. coli now that is also resistant.
She said there's an E. coli now that's now resistant to antibiotics. And so we are called upon in our own personal lives, that's part of it, and in our work lives to be really cautious about when antibiotic is needed. Okay, and then up on the management issues, so there's really three pieces. We're doing about prevention, management, and monitoring and tracking. So part of that management has to do with involving housekeeping and cleaning and what equipment we're cleaning. So we need to have policies around that and be doing it regularly and be monitoring how good we're doing at it. And finally, performance improvement. How many of you actually are tracking on paper or electronically your whatever it is you're working on? Those of you who said you had goals that you're working on, are you? Yes, thank you. Can you talk about what you're doing? Thank you, Jill.
Hi. We actually just started with our state, and we joined the C. diff collaborative with the state, and now we're reporting that to National Health and Safety Network, and we just started it. So,
what are you going to be working on?
Just tracking it, and you enter the information into the database, and they're going to use that information in the CDC to kind of get a baseline of what's going to be happening with the C. diff infections. And
Okay. So it's C. diff you're looking at specifically. Okay, thank you. Anybody else? You probably are, but you don't want to say it, huh? Okay. We're going to talk about the concept of community immunity, which, as I said before, is very simply focusing in on being a team, being knowledgeable, and caring about our care partners and the residents that we support and the families that are with us. So there's two pieces here. The action piece, which is we work together to prevent infections and the spread of infections. The outcome is the second piece. We protect each other. Because we work together, because we're knowledgeable, because we're caring, and we have a team, we are protecting ourselves and each other. And that's what this whole community immunity is all about. And the community is not just the residents and staff. It has to do with families, volunteers, and others in the community who may be part of our smaller community. You know, I was volunteering to do blood pressures one time at my church, and two young women came in. They were high school students, and they were in a health tract, and they were doing eye vision tests. It was one of those, the Lions van, and they were telling me about having shadowed CNA, and they said that CNA kept telling them how hard this job was. She said, it is so physically draining. And then pretty soon after a while, she said, did I tell you how hard this work is? And after about the 5th time of saying that, they said, well, if it's so hard, how come you do it? And she said, oh, I love it. And so what those girls came away with, the message was that this woman worked on a team. She felt part of it. She was cared for. It was hard work. She had that reality. But that's what community immunity is working with each other. And what it means, too, is that management has to create the setting and the structure for community immunity to happen. That means that consistent assignment is in place, that we have no-fault call-ins. We encourage people to call in. I guess some people call it call off. Don't come to work if you're sick, and you don't get in trouble for that. That there are programs that encourage and provide for free Fluogen, for immunizations for flu, and that we have all of the materials that people need to do their jobs. This is a book, if you've not seen it, you can order it from Pioneer Network website, or you can get it at the web store, the store here, or the web store, which talks about all of these practices to set up for a really supportive environment. So let's talk about the chain of infection. This is familiar to all of us. We start with a person who is infected. Here's some examples: MRSA, influenza, norovirus. Did you know that 30% of people who have norovirus don't show symptoms? So we're carrying, we got some carriers out there. Those germs have a reservoir inside the person where they live and move about and thrive. They leave that individual through mucus or orifices that get out. Anything that can get into the body can get out. Then they get around on our hands and on surfaces, and they make their way into another person, and now we have a second sick person. Excuse me. Traditionally, we have thought about the chain of infection, or infection as a chain, and that to stop the spread of infection, we had to break that chain. Usually that was identified as an individual who didn't wash their hands well or didn't clean up the surfaces, and so staff was the primary culprit. A new approach says that you're not the only one with hands in that building. The residents have hands, other staff have hands, families coming in, volunteers coming in. We need a multifaceted view of it, and we need a multifaceted view of action steps, approaches. We just went over this, but to be reminded, there's lots of ways that germs can get into our bodies. Breaks in the skin, I think we don't pay attention to as much. I never did figure out why the rectum and the vagina go away in this second picture. They're there, right there, but they went away. Interesting. So again, this is just another visual cartoon that depicts how this happens. Germs enter the body. These are good ways, pardon me, to educate staff about it too. The germ ends up in the air or on our hands or on some surfaces, and somebody comes by and touches it and then touches their face, and guess what? How are you feeling today, everyone? 95% of people who are exposed to a cold virus get infected, you know, all winter long. Well, actually, they are all year round. However, of those 95 who get infected, only 75% of those are symptomatic. So there's another 20% who are walking around feeling fine and perhaps not being as cautious as they might because they think they don't have anything to spread. Did you know that if you do experience symptoms, your body can continue to expel the cold virus for up to 7 days after you don't have any more symptoms? So what does that mean? Does that mean we should have people really policies where everybody stays home for a week and then another week? No, it's not practical. So what do you do in that case? Does anybody have a policy about colds or about symptomatic infection, about how long people should stay at home? Well, not that you have to have a policy necessarily about that, but we have to be aware of it. People do not have to stay away. It's not practical. We couldn't run our homes, but we do have to think about what is reasonable and when is the highest transmission period. Dr. Namali Stone, who is an epidemiologist at the Centers for Disease Control, talks about this policy of touch and take. So our awareness needs to be, what are people taking into the resident room with them? What do they touch while they're in the room? What do they bring out of the room and into another space? And how many things get cleaned? How many, how, and how frequently? So let's talk about how this web of transmission gets woven. How many times in an hour does a typical adult touch their face? Guess. Anybody? 10? It's more than that. Right in the middle. We touch our face, and as I look out right now, I can see there are a number of you touching your faces right now, just in your positioning. You know, we bring our hair back, we readjust our glasses, whatever. If we touch our faces 15 times in an hour, how many times do you think it's in 24 hours? It's 360 times. So, let's take that a step further. Show the pictures. How many times in an hour do you think that you touch a surface of some doorknob, a light switch, your phone, your iPad? 1 hour. What do you think? Guess. 50? A lot more than that. 270 times in an hour. So what does that make it in 24 hours? 4,000 surfaces. So we just got done talking back here about we touch our face 360 times in an hour, and 4,000 times we're touching all kinds of surfaces. So you can see the implication here. Our stethoscopes, glasses, dishes, med carts, etc. So let's look at it again in a cartoon depiction. We have an individual who has dirty hands and faces and is sick. We now have individuals who also are dirty but are not sick yet. So what happens here? We have a web developing, and you can see the spread is happening. So that contagious disease spreads quickly and in all directions. You know, when we find a person who's living with dementia who has left our building and we were wondering where did they go, and you start a search for them, and how we do that is looking at a radius of, a person can get a mile in 15 minutes. So every 15 minutes you have to go out another mile. And so that same thing, that same kind of concept happens here with the spread of infection. Thank you, Jolie. So when we clean most hands and surfaces, often, we have this sick person in the middle. We have what we started out to be a cadre of dirty hands and surfaces, but people are still healthy. Now we're cleaning people and cleaning surfaces, and so we have developed, we're shredding the web. We've developed a way to stop the spread of that with something we already do, except you don't have to raise your hand. I would say, ask you, how many of us routinely help every resident to wash their face and hands every single day and after meals? You don't have to raise, but my guess is I didn't do it. I know it wasn't done, and I see a lot of places now. So we are able to contain the infection by very simple actions. Part of our responsibility is to involve families, and there is a family brochure that I didn't put on the website for you, but I can show it to you and we can get it to you if you'd like to have it. It's just a simple, it has 8 pages, but there's not very much on each page, which is a basic education about infection and the kinds of things we're doing now in our home that your relative is staying in, and we'd like you to be a part of our plan. And you can do so by being aware what you touch and take, and about hand washing, and and they can be a part of washing surfaces as well. We're not asking them to do our job, we're asking them to be on the team. So we didn't bring it this time, but how many of you have used in your education a product like Germs? Yeah, you know what that is. So I think the thing for me that Germs does, and that's so helpful, is when people have their gloves on, you know, they put their Germs on, like the germs are on their hand, they put their gloves on, but when they go to take their gloves off, they're very careful, but there's a ring of germs that are still left around. So it's a really good illustration of that and how it can be transmitted by just handshaking. So, you know, we talk about culture change, and person-directed care is all about compassion and touch. And so we want touch to happen, but we have to, at the same time, be careful about being clean. So by comparison, our traditional way of looking at infection control was a chain, a kind of a round chain that staff hands was the primary vector, that one person was responsible, and that there's limited visibility of infections. Community immunity has us thinking about our community and doing it together, and that transmission happens through a web, that we have capacity to shred that web and make a difference in by cleaning resident hands, faces, surfaces, and staff and visitor as well. That we provide immediate access to all of us about how we're doing, what we're working on, what we're measuring, and what's our progress, and that the whole community is working together. Kimberly Clark did a study of a nursing home in Pennsylvania in a long-term care setting, and they implemented community immunity in using education, special products, and monitoring. This all came together in a program or a model called Heroes in Prevention. So everybody gets to be a hero. You could provide capes. The components are training and development and engagement, community awareness and education, getting products available that they can use, and then the data collection and having it available in real time. So let's just briefly go over to build community and to get another cough drop. Bad timing for this. To understand and elevate the role of the direct care worker, that they actually may have a specialty role, a leadership role in community immunity. That we talk about not just what the assignment is, but why is it we're doing this? Sharing that face touching and transmission and surface touching can play a big part in transmission. Community, you guys can see that these guys, they're wearing Heroes in Prevention t-shirts. They're a team. They have a weekly meeting. They have updates so they can see what's our progress been, how good we did, or did we slip back this week and we got to pitch in a little harder next week. So there's feedback regularly. And these products, as I said, are available. And it's fun. We're working together. Residents can have the t-shirts too. So this isn't like products out of the chemical laboratory that we're buying. They're simple products. We don't use those Sani wipes with chlorine in them for residents to wash their faces. Of course not. But I don't see very many nursing homes that has good wipes available for residents. Does anybody here have them? Hand wash? Okay. And then, of course, we want to have sanitizers available, right, that staff can carry with them. And then some surface products, some kind of disinfectant spray and non-binding wipers. So a way to get some feedback to measure is to use some monitoring tools. And I don't know how many of you have used or seen the ATP luminometer, one of these. Who has seen this or uses it? Well, this is a fantastic tool whereby we use it helps us, ATP is the energy molecule that's in all plants and animals and mold and bacteria. So when we clean a surface, we want to get that bacteria off of there. This is a way, it measures through light, lumens, to swab a surface, put it in here, easy way to flip it up, do your survey. There's a little procedure for how you do it. Put it in here, there's a little reactant in here, and then you can press this thing and it will read for you how good you did on your cleaning. So it's a way that you get immediate feedback, and we were doing a few of these ahead of time, but the swabs are not working properly today. But generally, if we do this, we could do a little somebody's cell phone, and you would be really embarrassed at how much bacteria there is. And then we have you take a swab and watch how many in here actually wipe off your phones regularly. Yeah, I don't. I don't think to do it, but anyway. So this is a tool called an ATP luminometer or meter that helps us, gives us immediate feedback. Now it's about $1,300 to buy one, but if you have several buildings, you could share them. Or if you participated in the Heroes in Prevention program, you get some equipment, and this is part of that equipment that you that would be part of your package. And then another part of that, so collecting the data is good, but then we want to have access to seeing it and seeing where are we and how does it look. This cloud-based Heroes in Prevention live system is a way for us to have a line of sight visual to the infections tracking and mapping. You can map where are they happening in the, excuse me, in the building, the time of a week, the time of month, the time of year, etc. You get automated updates on hand hygiene compliance, how good are we doing, surface cleanliness and team outcomes, and have also is included a dashboard. And what's another way to measure if your staff are doing cleaning and good hand washing? How do you know if they are? You can look, but, and not just those of you who are in management positions. Your coworker, you want your coworkers to be doing good because you want to be kept safe. How can you tell? Pardon me? Less infections would be one way. What else? How much? Yeah, if the product supply is going down. Thank you. All right, so this is, Kimberly Clark did this study for 8 months in a nursing home in Pennsylvania with 165 individuals living there. In 8 months, of course, they looked at the previous frequency of infection. In 8 months, after implementing the education, the products, and monitoring, in only 8 months, upper respiratory infections were decreased by 44%, pneumonia was decreased by 46%, and GI infections by 56%. On a whole, there were 54 less infections. If they took that out to a year's time, it would be 90 less infections, because this is just 8 months. So that is a pretty dramatic, it's only one nursing home, but it is a pretty dramatic illustration of what can be done. Let's go through a few myths to infection control. Number one, if the surface looks clean and smells clean, it probably is clean. This luminometer that I just showed you was used, ATP readings, was used to measure some various surfaces in the nursing home. The worst one right here is the cart handle, the nurse's cart handle. The next bad one was the nurse's bathroom toilet seat. Then we have the outdoor door going to the outside of the building and call button. You can see the various ones on here. But it's a way for us to sit up and say, oh my gosh, I didn't realize that we were that bad. These are, we call them hot spots. And I didn't mention before, but anything with a reading over 100 is considered contaminated. I went to a restaurant one time when I was learning how to do that a couple of years ago, and sat when the waitress wasn't coming around, and so we had the machine we were looking at. So I put the machine and put this up on the like this on the table. We did it on the table, and it was terrible. It was like 500. So then we washed it off with one of our wipes that we got there. Yeah, and it was good. You know, that's the health inspectors go around and do that. In my town, every week there's some restaurant that gets a report. So we tried to do some readings in the building, in this room today, but our swabs were not working properly. But you can do various ones, and it's makes you stand up. So let's just think about the 3 levels of cleaning. Cleaning is just removing visible soil. Disinfecting is the process that eliminates most germs except spores. What develops spores these days that were, yeah, C. diff. Because it can develop those spores and just hang out until the conditions are right, and they'll pop up again. Sterilization, however, will take care of spores as well. So our second myth, we're below the average, if you're in your home and saying this, I'm below the national averages for infections, so we're doing pretty good. CMS has us reporting on urinary tract infections. They have us look back for 30 days. Well, the research team, and the national average is 6.4 for urinary tract infections %. The research team started thinking, this doesn't make much sense. Looking only back at 30 days, what if we looked at the whole year? And because it skews it. What they found was that nearly half, 46% of elders over the year developed a urinary tract infection. This is the number of people, not the number of infections. So one person could have gotten 2 or 3. The annual levels of communicable infections are also alarmingly high. 3 in 5 people will develop an upper respiratory infection in a year's time, 2 in 5 pneumonia, and 1 in 5 a GI infection. Nearly half of the people that developed an infection the first time got an infection the second time, and they got it within 3-month time period. So you have to be thinking in your mind, oh yeah, I bet you if we just got in there with those wipes and we did a better job with hand cleaning with everybody and the surface cleaning, what kind of an impact could we make? This is kind of scary. 2010, a study was done. Hand hygiene compliance, 40%. 60% of us suck at hand washing. Physicians had a lower compliance rate, 32% of those guys or gals, and only half of the nurses. Gloves protect the wearer, but do not protect others when surfaces are soiled. And they just decided to do some observation. 40 hours of watching. One resident was seen with assistance to get their hands washed. Imagine the impact on infection control if we just helped people wash their own hands and kept themselves clean. Third myth. The impact of poor infection control is limited to care staff and residents. Of course not. There is a horrible, horrible human toll. People, what happens when we go to hospital in terms of ADL performance? When an elder goes to the hospital for 4 days and they come back, do they have all the same functional capacity as when they went in? Rarely. So we have to help with that. People get sick. There's a lot of family stress. And we've already talked about the financial toll, both on staffing and on treatment. And reputation toll. Go back there, that slide that said 50%, 46% of people got urinary tract infection. Whoop-de-doo, do you want to take your mom to a nursing home where there's 50-50 chance where she's going to get an infection? That spreads. The fourth myth is that mouth care is a nicety and not an infection control issue. We know that is not, of course, the truth, but let me just ask you, what is one of the first things that people put aside when we don't have enough staff? Of course, that's the answer I wanted. Oral disease, either plaque on the teeth or gingival gum disease, can cause pneumonia. People can have upper respiratory, 2 ways people get pneumonia. They either aspirate junk off their teeth, bacteria, or in the gums, or they can have an aspiration pneumonia. And good oral care, as I'm going to show you, can help to prevent that. That is a lot of control, a lot of power for a CNA or a direct care worker to know I have the power to prevent somebody from getting pneumonia or even dying. So this is just another statistic about hospitalization. So the person who gets pneumonia, 7 days is the average stay, and there's a loss of ADLs. Simply being dependent on another person for oral care logically increases the risk for pneumonia. This Japanese study that I showed you at the very beginning showed that when oral intervention, oral care was done in a group who developed pneumonia, the deaths were half what they were when oral care was not given and the person got pneumonia. An American study found the exact same thing, that in a group of elders that did not receive proper oral care, there was more than 3 times, what am I reading here? 3 times that of the group that did receive oral care. So we know that. We know it gets neglected. 82% of CNAs say they don't do it because they don't have enough time. One blind study in Kentucky watched how long did they spend brushing teeth, and they found that it was 16 seconds. Oh, excuse me, that says only 16% of residents received oral care. But there's another statistic that says the same thing in terms of seconds. 72 to 84% of nursing home residents have trouble brushing their own teeth. We know that. And here, 16.2 seconds was the average time. And we know this. Behavioral issues can get in the way a lot. So here is a picture of some really bad oral plaque that within 6 months of a CNA providing really good oral care, the CNA did that. That's very powerful. That person could have gotten pneumonia. That person could have died. Here you can see is gingival disease, gingivitis, and after 6 months of CNAs taking care of this mouth, this is the result. You all are aware, or are you, of oral care without a battle? It's another bathing without a battle type program, and that's available for sale in these kinds of pictures to help with your education. The thing I guess, there's lots of ways to try to help people relax so that they could get their teeth brushed. And this is an area too where there can be a champion CNA to help lead or be the person to help others learn. When you suspect an infection, it's better to treat with an antibiotic just in case. Well, of course, we know that is wrong, but we also know a lot of places do it, particularly with urinary tract infections. You see a behavioral change in the resident, it's probably a UTI. This statement is out of date as much as this picture of this nurse is out of date. Here's the big 7, urinary tract infection. Before we consider anything, ask and answer these 7 questions. Could it be this person is dehydrated? What percentage do you think of people living in nursing homes are dehydrated? I don't know the specific, but it's a lot. Could it be a medication side effect that's making this person feel like they have to pee or that they're having some other discomfort? Could they be coming down with a viral infection? Did they just not sleep well and that's why their behavior has changed or why they're complaining? Could it be pain? Could it be stress, anxiety, depression? Could it be constipation? All these 7 things, and probably more, should be asked and answered before we think about, is it a urinary tract infection? The likelihood of a urinary tract infection being the cause of a behavioral change or some complaints can be very strong, somewhat strong, or weak. There are some nonspecific signs and symptoms in the middle and some specific signs and symptoms for urinary tract infections. We should not, just because, I'll go back here, you'll have that on your slide when you print it off. Urinary tract infections are overdiagnosed and overtreated. Nurses in long-term care often, if the urine smells bad or looks cloudy, does not necessarily mean it is an infection, but we just have a hard time not treating that. We need new urinary tract symptoms that didn't used to be there. People who can have asymptomatic bacteriuria or colonization in the urine, that does not necessarily mean an infection. We have already talked about back there developing some guidelines as part of our infection preventionist plan, using narrow spectrum antibiotics rather than, in other words, one that is specific for whatever bacteria is found in there. And this is that big nurse in the sky who's saying you got to treat everything. These are some examples of downloadable posters that you can get and move, have in your, oh, it's right here, have in your community. So, as we pull this together, community immunity is pulling together all the stakeholders, all people who have any kind of involvement or connection. Hand hygiene is for all of us. That's not new to you, but bringing it to the surface when we're away from the work setting and saying, are we really doing as good as we can doing? Who in your buildings does the surface cleaning right now? Does anybody have, other than the housekeeping, doing surface cleaning? One person. So we might think about that. Are there times when it's just within the rhythm of the work pattern that other people can contribute to surface cleaning? This is what one, maybe you guys have a system like this, but this was one nursing home that had several rollable carts just ready with all the stuff that they needed, so that if, when isolation came up or they needed equipment somewhere, they could just take the cart and go right to the unit instead of having to collect all the stuff. So I didn't say, you're kind of a quiet group, and I didn't say at the outset you should chip in when you had something to say, but are there any questions or things that you have to contribute at this point?
I have a question. So I'm assuming, or I guess I'm wondering, the wipes, are they antibacterial? Because there's a lot of research right now about how antibacterial soap is actually leading to superbugs.
Uh-huh.
And so was there any consideration of that during some of the research presented today?
Well, I actually might toss that back to the team here from Kimberly Clark. Do you have a response to that?
Absolutely. So as you know, for example, triclosan is big on the news right now. There's a lot of resistance associated with then other environmental harmful effects. So when we make our products, we work closely with the regulation, the FDA, and look at studies to make sure that we're not adding to the resistance, right? So some of the active ingredients we use in our soaps, we have benzalkonium chloride, which is very safe, and we have it in limits that have been proven not to create those resistant bacteria. So we always encourage hand washing whenever possible with just regular soap or antibacterial soap in communities where there is risk of infections, because there are certain infections that you cannot kind of clean them with regular soap. We also have hand sanitizers as well, and sometimes alcohol is actually does not create as much resistance as some of the antibacterial agents we have. So when we recommend products, we look at the big picture of the type of infections available in those communities. Disinfectant wipes are very important. We talked about spores, C. diff, and various germs that we have. So we've done studies focusing on those germs, again, specific to the elder care community. So when we recommend products, we look at the settings. So what we recommend for schools, for example, is different than we recommend for hospitals or elder care communities or, bank or a stadium. Absolutely. So we take that into consideration. And we'll always make sure we're up to regulatory, the EPA standards, FDA standards, that we're creating a safe environment and we're not adding to the problem. Does that help?
Yeah, I didn't mention, but I see this happening, and I'm not sure people are always aware. It takes 15 to 20 seconds to let the gel or the foam or spray or whatever it is to dry, and I see people put it on and then going about their business and not waiting a few seconds. Anybody else? Well, yes.
My name is Larissa, and I am a recreation team member from Schlegel Villages from Canada. And in our home, we help our infection committee to fight diseases. So as a recreation team member, we are cleaning surfaces and residents' hands before and after each program. And after big events like pub night, Main Street performances, it's our responsibility of recreation team members to clean the handrails. And definitely if the accident would happen during the day, we are trained to clean the surfaces and the floor or any equipment.
Does anybody else have practices where other than nursing that you'd like to share? Or doing cleaning? It's coming.
I was going to say that's wonderful because honestly, sometimes just hand washing with just regular soap or water or using hand and surface wipes that do not contain any active ingredients can actually reduce germs, just the act of friction. So in that bag, we have our hand and face wipes. We don't have any active ingredients. So just using that can actually reduce germs off your hand by about 75 to 80%. So that is a good practice to have. So it's not always antibacterial soap, right? That's catered to specific germs. So just wash your hands, or that's why drying your hand with a towel is very important after that. So it's great that you guys do that. That's wonderful.
I'm going to, Arlene, would you take those around and put a couple on every table? What I'm having passed out for you now is a 4 levels of infection prevention that you might consider that will help you to determine where you are on your infection prevention plan in your own community. So I'd like you to, at the table, you can, if there's enough, everyone can have one, or you'd have to share them. And I'd like you to just read it over and see at the different levels the actions that you're taking in your community, and what level would you be at, and what else might you do to bolster your program. And then if you could jot down some notes about what would you like to add to your plan, what would you like to take home to do, and then we'll have you share that with other people at your table. Would anybody be willing to talk about something that you'd like to pick up when you go back, or to enhance your program? Yeah, I'm just asking if anyone had anything you'd like to add. Well, feel free to continue to talk at your table. Feel free to get some of the on the giveaway table here, and I'll be up here, and the Kimberly-Clark team is here. If you have any questions, please come up and catch us. All right. It is. Oh, yeah.
Okay,
The
Linda,
CE.
thank you so much
Oh,
for
wait,
that.
I want to say one more thing. Let me just say one more thing for you. I do want to, if I can get your attention just quickly so we can wrap up here, I do want to review our take-home messages. And that is that we can and should do better paying attention to hands, hot spots, and faces, and remembering how many times we touch. Using antibiotics wisely, our stewardship, seeing mouth care as an infection control problem, and really boning up on the oral care programs. Creating community immunity in your plans. And if you choose to use the Heroes in Prevention program or model, you can talk with Kimberly-Clark folks. And engaging everybody on the team in our community and helping us to do so. Thanks.